Welcome to Lecture 5 of AI in Global Health. Today's topic is going to be about developing, conducting, monitoring and evaluating IR projects. In previous lectures, we've looked at what IR research is in the bigger picture, how to contextualize global health challenges, and how technology can be used in IR. Today, we're going to go into the specifics of how IR is actually conducted. From this lecture, we will learn how to develop a strong research proposal, how to determine the right methodology to use, and lastly continuous monitoring and evaluation of your project. This is just a reminder of what the IR cycle looks like. Today, we're going to be looking at the bulk of this, so steps 2 to 6. We'll start at what an IR proposal entails. So, what is a research proposal? I'm sure most of you know, a research proposal is a document that describes the proposed research, why it is being conducted, the research design, and the expected impact. A proposal is a requirement for most grant applications. To be effective, you need to know what you are doing, why you are doing it, when you plan to do it, and how you plan to do it. What's different about an IR proposal? The goal of IR is to facilitate uptake of interventions by end users, and to develop policy recommendations and practical solutions. So, your research proposal needs to originate with a problem identified and prioritized by end users. Encouraging end-user uptake of research results requires end-user engagement in all steps of the research process, including proposal. So, what are the components of a IR proposal? We have the introduction, which includes the title, rationale, problem statement, objectives and literature review, the research design, which describes the participants, data collection methods and tools, ethical considerations, the project plan, which specifies the timeline, research team, budget and justification, impact, which involves a monitoring and evaluation plan, capacity building plan and dissemination plan, and a final supplements section. So we'll start by talking about how to develop a RQ. When developing a research question for an IR project, you want to make sure your RQ is informed by the specific context of the population and problem it targets. This would involve evaluating the distribution of health needs, the risk factors involved, the quality and accessibility of ongoing interventions that already exist, and the reasons for missing targets. As described in Lecture 3, this can involve things like the political state and cultural context as well, and the acceptability levels of certain intervention types. Here, we have an example of a problem situation. In District Y, which has a population of 145,000, sanitary conditions are poor with 5% of households having toilets. Diseases have become widespread and are connected to poor sanitation. Diseases such as hepatitis, gastroenteritis, and worms infestations are very common. The Department of Health has initiated a sanitary project that aims at increasing the percentage of households with toilets by 15% every year. The project provides materials and the population is expected to provide labor. 2 years after the program began, less than half the target was reached. So when evaluating this situation, a couple of questions you might want to think about are, what is the discrepancy? What factors can explain this difference? Are there service-related factors? Population-related factors? Physical factors? Please pause the video here to reflect on these questions. As you begin to think about developing a research question, here are some key objectives you should ask yourself. Firstly, think about how relevant or urgent your topic at hand is. Who is affected by the problem? What are the economic impacts? It's also important to look into what existing interventions already address this situation, and perhaps what gaps they don't currently address. Think about how applicable the results of your project would be. Would your recommendations be accepted by the target community? Will it benefit policymakers and funding agencies? Or perhaps, will it help evaluate the ongoing interventions that already exist? And lastly, feasibility is a critical factor to consider. Think about what data is actually available for you to use, and whether you would be able to realistically complete your project within a year or two. Moving on, another critical piece of implementation research is the monitoring and evaluation components. You will need to include this in your proposal as well. This refers to a plan of exactly how you will assess whether or not your project is meeting its objectives. Within the monitoring component, you will describe the resources needed for the project and how you will monitor the responsibilities and activities of each team member. The evaluation component will describe the methods you will use to track the outcomes of your project. Finally, you'll also need to include a dissemination plan in your proposal. This refers to how you plan on spreading your findings to the stakeholders involved, and to the public. Unlike traditional research, implementation research is directly concerned with how evidence-based practices are adopted, adapted, and sustained in real-world settings. Because of this, dissemination is not an afterthought, it is an integral part of the research process from the beginning. Some example dissemination activities are listed here, such as presenting your research findings at national and international conferences or distributing your research findings in the media. In IR proposals, this section typically includes things like the actual names of academic and professional conferences you plan to attend, or educational presentations you may attend during each year of the project. We will now talk about what a real IR project could look like. Let's explore some different research designs and methods commonly used in IR projects. These are some key research designs commonly used in implementation research. Each of these designs helps us understand how and why an intervention works, or doesn't work, in real-world settings. Let's begin with the before-after or time series design. This design involves introducing an intervention and then examining outcomes before and after its implementation. It's useful for understanding change over time in the same setting. For example, researchers might look at healthcare access before and after the introduction of a national health insurance policy to see whether the policy led to improvements. Next, we have comparing the intervention to control groups. This is a quasi-experimental design where outcomes are compared between groups that received the intervention and similar groups that did not. A practical example of this would be comparing maternal health outcomes in districts that adopted a new care approach versus outcomes in districts that did not. The goal here is to identify differences that may be attributed to the intervention. Another powerful approach is the cluster randomized controlled trial, often used when individual randomization isn't feasible. In this design, groups, or clusters, such as communities or health facilities are randomly assigned to intervention or control conditions. For instance, in a study on tuberculosis treatment, 10 districts could be involved, 5 randomly selected to implement mobile phone reminders for patients, and 5 serving as control sites without the reminders. This helps establish a causal link between the intervention and observed outcomes. Finally, we have the repeated measures design. This involves collecting data from the same population at multiple points, possibly using different types of data or interventions. A good example is studying how retirees use health services over time, using a combination of surveys, interviews, and health records to explore the key factors influencing their healthcare-seeking behaviors. Each of these designs offers unique insights and is chosen based on the research question, context, and practical considerations in the field. Now, let's turn our attention to some qualitative research methods. Qualitative research explores values, attitudes, opinions, feelings, and behaviors, things that are often difficult to quantify but are critical for understanding how interventions are experienced and implemented in real life. It's particularly useful for generating theories, informing policy, improving practice, justifying change, and highlighting social issues that may be overlooked in quantitative work. Rather than predicting outcomes, qualitative research provides rich, descriptive, and explanatory insights. Let's begin with in-depth interviews. These are purposeful, one-on-one conversations guided by the researcher using a flexible interview guide. The goal is to encourage detailed and thoughtful responses, without steering or leading the participant. These interviews are typically recorded and later transcribed for analysis. Each session usually lasts around an hour and provides deep insight into individual perspectives. Next, we have focus group discussions. These are facilitated group conversations, usually lasting 1 to 2 hours, with about 6 to 10 participants who share similar backgrounds or experiences. The discussion is guided around specific topics but is intentionally informal to allow beliefs, opinions, and motivations to surface naturally. One of the strengths of focus groups is that participant interaction can enrich the data, as people build on each other's thoughts or challenge each other's views. Finally, field observation offers a window into real-time behaviors and interactions. This method involves systematically observing verbal and nonverbal behavior using structured recording tools. Researchers might immerse themselves in the setting as participants or observe from a distance. Through note-taking and detailed documentation, they capture the nuances of everyday practices, often over extended periods of time. Together, these qualitative methods provide critical insights that help explain the mechanisms behind implementation success, or failure, and can guide more contextually grounded and effective interventions. There are many quantitative research methods in implementation research. These methods are designed to collect and analyze objective and numerical data. The strength of quantitative research lies in its ability to produce generalizable findings, test hypotheses, and assess the strength and direction of relationships between variables. Common data collection strategies in quantitative research include structured observations, questionnaires, and performance-based instruments. These tools are designed to reduce bias, ensure consistency, and allow for statistical analysis. One widely used approach is quasi-experimental research. This design examines cause-and-effect relationships by manipulating one or more independent variables and observing the effect on dependent variables. While it often includes intervention and control groups, the groups are not randomly assigned, which distinguishes it from true experiments. For example, we might evaluate whether introducing a new patient tracking system improves clinic efficiency by comparing outcomes at clinics that adopt the system versus those that don't. Another important method is correlational research. This approach looks at the relationships between variables without manipulating them. Using correlation coefficients, which range from -1 to 1, researchers can describe the strength and direction of relationships. A strong correlation, for instance, might suggest that as staff training hours increase, patient satisfaction scores also rise. While this doesn't prove causation, it can inform further research and even support predictive modeling. Finally, monitoring and evaluation research is a core part of many implementation studies. It involves tracking progress against the original intervention design, identifying weaknesses, testing assumptions, and adjusting strategies as needed. M&E often relies on routine health information systems, but it may also include special surveys or targeted assessments to capture more specific or timely data. In summary, quantitative methods help us measure and compare outcomes, understand patterns, and evaluate the effectiveness of interventions in a structured, evidence-based way. Finally, we have mixed methods, which combines both quantitative and qualitative methods in a single study. This allows us to draw on the strengths of both approaches, providing robust numerical data while also capturing the depth and context of lived experiences. There are several key designs in mixed methods research, each with different purposes and structures. First, we have the sequential explanatory design. In this approach, researchers begin with quantitative data collection, which is then followed by qualitative data. The goal is to use the qualitative findings to explain or deepen the understanding of the quantitative results. For example, if a survey shows that a large number of patients are missing follow-up appointments, in-depth interviews can help uncover the reasons why. In this design, more weight is typically given to the quantitative data. Next is the concurrent triangulation design, where quantitative and qualitative data are collected at the same time. The aim here is to compare the two datasets to see whether the findings converge, diverge, or complement each other. For instance, while surveys might indicate that healthcare providers are satisfied with a new digital tool, focus groups might reveal frustrations that weren't captured in the numbers. In this design, equal weight is given to both data types. Then we have the sequential exploratory design, which takes the opposite approach of the explanatory model. Here, qualitative data is collected first, often to explore a new or poorly understood issue, and is followed by quantitative data collection to test or measure the initial findings at scale. For example, interviews might uncover a new patient concern, which is then assessed across a wider population using a survey. In this case, greater weight is given to the qualitative data. Finally, the concurrent embedded design involves collecting both data types at the same time, but one is clearly primary while the other plays a supporting role. For example, a primarily quantitative study might embed a few interviews to provide context, or a primarily qualitative study might include some survey data for background. This approach is particularly useful when one type of data alone cannot fully answer the research question. Overall, mixed methods research gives us a more comprehensive understanding of implementation by integrating numbers with narratives and structure with meaning. Now, we are going to talk a bit more about the monitoring and evaluation portion of IR projects. As mentioned before, monitoring and evaluation methods help us assess the reach, relevance, and impact of our work beyond publication, and also identifies any changes that should be made during the course of your project. Importantly, it takes place during the process of the project, not after it is completed. There are several useful methods for this purpose. First, we have the information log. This is a running record that helps keep track of all feedback and external engagement related to the research. It might include comments from stakeholders, related news coverage, blog posts, or media mentions. Importantly, it also tracks how often the research is being cited in academic literature. Over time, the log provides a snapshot of how the research is being noticed, discussed, and applied in various contexts. Next, we use surveys to directly collect feedback from stakeholders. These are typically administered to members of the target audience. This could be policymakers, healthcare providers, or advocacy groups. For example, a questionnaire might be sent out 6 months and again at 1 year after a research briefing or workshop, to assess recall, relevance, and use of the findings. These surveys can help identify both the reach and the perceived usefulness of the research over time. Lastly, interviews, particularly with key informants across different levels of the health system, are a powerful way to explore whether and how the research findings have influenced decisions, policy, or practice. These interviews go deeper than surveys, allowing researchers to ask probing questions and understand the context in which research findings were considered or implemented. They also help uncover barriers or facilitators to research uptake. When creating an M&E plan, here is an outline of 4 main steps that are commonly involved. The first step is stakeholder consultation. Before deciding on indicators or methods, it's important to engage with the people who are directly involved in or affected by your project. These may include health workers, policymakers, patients, or community leaders. Consulting stakeholders early helps ensure that the indicators you select are not only appropriate but also useful for those who will rely on the evaluation results. It also ensures that the plan addresses real needs on the ground, rather than assumptions about what's important. The second step is to translate your project's goals into variables that can be objectively measured. This is where the logic model matrix becomes useful. The logic model helps you break down your project into its core components, activities, outputs, and outcomes. For each of these, you can then identify indicators that will help you track progress. For example, if one of your project goals is to improve the quality of care in health facilities, you might measure this by tracking staff training sessions, an activity, improvements in clinical skills, an output, and better patient outcomes, an outcome. Next, in the third step, you'll need to assign responsibilities for implementation. This involves developing a clear data collection plan that specifies who will be responsible for collecting which data, how data quality will be ensured at each stage, how often data will be collected, and what format the data should take. This step is crucial for making sure the plan is actually doable in practice. Everyone involved needs to know their roles and have the tools and support needed to carry them out. Finally, the fourth step is to set targets. Working with stakeholders, you'll define what success looks like for each indicator. Setting targets gives you a concrete measure to assess whether the project is progressing as expected. A useful way to organize this information is in a table that outlines each objective or evaluation domain, the indicators you've selected, and the data collection methods and targets for each. By following these steps, consulting stakeholders, identifying measurable indicators, assigning roles, and setting targets, you'll have a clear and actionable M&E plan that not only tracks your project's progress but also supports learning and improvement along the way. Here, we have a real-world example of how a monitoring and evaluation (M&E) plan was created and implemented, this one from the Tanzania National Voucher Scheme, TNVS, which ran from 2003 to 2007. The program aimed to scale up the use of insecticide-treated nets, ITNs, among vulnerable populations using a voucher system. The first step in developing the M&E plan was to engage relevant stakeholders through consultation. The M&E strategy was developed during a series of scheduled meetings with partners in the program. These included officers from the National Malaria Control Program, the organizations responsible for distributing the insecticide-treated nets, and researchers from the Ifakara Health Research and Development Center and the London School of Hygiene and Tropical Medicine. This collaborative process ensured that the M&E strategy was both relevant and practical, as all key players had a voice in shaping it. Once the stakeholders were aligned, the next step was to define indicators to track the program's impact. The team identified 5 key domains for evaluation: insecticide-treated net coverage among the target groups, such as pregnant women and children under 5. The provision and use of reproductive and child health services, as the voucher scheme was integrated with these services. The issue of voucher leakage, including non-target groups receiving vouchers or vouchers being used for items other than ITNs. The effect of the voucher scheme on the commercial ITN market. The cost and overall cost-effectiveness of the voucher program. These domains helped guide the selection of specific indicators to monitor progress. The data collection methods for each indicator were also chosen, as seen in this table. Please pause here to examine the table. With indicators established, the next step was to assign responsibilities for data collection and analysis. Independent researchers from IHRDC and LSHTM were tasked with conducting the M&E activities. They were responsible for collecting and analyzing the data, and reporting the findings back to the program implementers, which included the National Malaria Control Program and other partners involved in the ITN distribution. This clear division of roles ensured that the evaluation was carried out effectively and the findings were actionable for those making decisions about the program. Finally, the team set targets for the voucher program. These targets helped measure the effectiveness of the scheme in specific areas. For example, targets were set for the impact of the voucher program on ITN use among pregnant women and children under 5, as well as for RCH service use and the effect of the voucher scheme on RCH service provision. Other targets focused on pregnant mothers' knowledge of the voucher system, their use of ITNs, and their understanding of malaria in pregnancy. So, those are all the major components of developing, planning and conducting an IR project. To end off today, we have a reflection question. How can you distinguish between an implementation failure and a failure of the intervention itself? Thank you all for your attention today. Next lecture will be our last, and we'll be talking about ethics and equity considerations in implementation research.